You're listening to the Addiction Medicine Podcast, the official podcast of the Governor's Institute. If this is your first time listening, thanks for joining us. The Addiction Medicine Podcast is designed for healthcare professionals and others interested in addiction medicine and will feature thoughtful conversations and insights from clinicians, patients, and families, policymakers, and other stakeholders. Remember to make us a favorite wherever you get your podcasts. You can also stay connected with us at governorsinstitute.org or follow any of our social media channels at @govinst.
Episode 3, in the second season of our Addiction Medicine podcast, will address some of the unintended consequences of the 2016 CDC Opioid Guidelines, which were widely misinterpreted and implemented. Hi, I'm Jeremy Kroom, Addiction Medicine Special Projects Coordinator at the Governor's Institute. This season, we're featuring some of our most popular and engaging talks from our Addiction Medicine Conference this past spring. Our expert for this podcast is Dr. Stefan Kertesz, a professor of medicine at the University of Alabama at Birmingham and an attending physician at the Birmingham VA healthcare system. Dr. Kertesz has published research and commentary on opioids since 2008. After 2016, when the CDC issued its opioid guidelines, Dr. Kertesz began researching and writing about the unintended consequences of the guidelines, especially for stable patients with severe chronic pain who were subject to prescription opioid reductions or who lost access to the medications altogether. Here's his talk from the conference, Irrational Exuberance, Incautious Stoppage, Lessons from Our Prescription Opioid Story.
Thanks everyone for the chance to speak. Let's move forward. This talk will combine some policy history about our story with opioids. It'll include evidence and science and my own opinions, but the opinions are not positions of the U.S. Department of Veterans Affairs, which is one of my employers. I do not own pharma stock. I previously owned some shares of CVS very briefly in 2020, but I had them sold as soon as I found out they were bought. My spouse has her own accounts and owns Johnson & Johnson, which has been named in opioid litigation. I personally was asked and turned down all requests to work in national opioid litigation. So we're in an interesting time. I spent some time this autumn watching Dopesick on Hulu. I don't know how many people might have seen it, but the story in that show echoes and in some ways is different from the story in the book by Beth Macy. But the key points really focus on ravenous marketing, denial of what was going on by one company, Purdue. I'm going to touch on Beth Macy's book, which I really enjoyed. There are a lot of books on the U.S. opioid story. In her book, slightly different from the show, there's a real emphasis on the impact of widespread availability of prescribed opioids that were easily diverted within suburban and middle-class families, not just working-class minors. The book, in many ways, defies the expectations of who could fall through the cracks in terms of addiction. And in reading the book, I felt a lot of outrage at Purdue. I felt a lot of kinship with the doctor, particularly Art Van Zee, who's in the book describing his frustration with seeing what's going on in the community around him. Among most books on this crisis, however, it's really important to acknowledge that patients with pain are not part of the story. In the Hulu show, there's not a single patient who receives an opioid who is not harmed by that medicine in the show on Hulu. And that's an important oversight. Part of the reason it's an oversight at this moment is that we are in a different phase of the story. Although many people are familiar with the rise in overdose related to illicit fentanyl and analogs, there's been a real decline in the prescription of those opioids, which was expected to produce a benefit. This is a slide shared by the Food and Drug Administration in October. It shows prescriptions per capita through 2020, so it's missing 2 years of data. But if you look at the orange line, you can see that by 2020, prescriptions in the United States per capita had reached the level last seen in 1993. Another way to think about it is we often reference the US being the largest consumer of opioids in the world. I'm sure in gross milligrams we are. But in per capita, we fall into 8th by 2019. We're probably quite a bit lower than that now. So we're in a different phase of the problem. As we reduced, there were some emerging ramifications, which are really the thrust and the reason that I'm prepared this talk. Starting in 2016, I both heard about and was witness to many traumatic events. This one was covered on Fox News, but I also read the medical record here on the left-hand side of a death related to suicide of a veteran, although not cared for by the VA, where the individual was highly disabled, ultimately decided, was told by the doctor's office in Tennessee, look, we're going to do a 25% cut at your next visit. They had already cut his doses 20%. And it's the Lawrence family, just to get the name. Meredith Lawrence is the spouse. And at that point, he decided it was time to die. And his spouse actually purchased the gun and was present with him when he shot himself. And she was, of course, charged and criminally convicted for that. But they were responding to a high level of disability. And we're going to come back to this issue of suicide. But even as recently as last week, the revision to the CDC guideline was covered on NPR. There were many comments, but I was one of the people they interviewed, that maybe there was a problem with the 2016 guideline. Could there yet be problems with the revision that they're going to issue? So this is already thrust to the front right now. The agenda for this talk is to talk about how we embraced liberal prescribing of opioids. And then how did the policy shift to rapid reduction? I think there's a tendency to say, oh, the CDC caused it, or to point a finger essentially and say that's who caused the reduction. But I want to talk, at that point, I'm going to turn to the issue of those long-term recipients, the 8 to 10 million Americans on long-term opioids, to talk about the evidence for or against taper or stoppage in long-term recipients, really about both forms of evidence, and to offer a little bit of a clinical framework for how I think about care of patients with pain, that takes the safety tips and puts that in the context of a relationship. So this is not a how to prescribe opioids talk. But at the end, I'll conclude with how I think about the relationship with the patient. In a way, I'm providing a little bit of review, but I think it's important to use policy scholarship to understand what happened. The policy scholars are people who study how policies happen in a country. And one of the most interesting concepts they come up with is something called a policy monopoly, which is when a collection of agents control the definition of problems that deserve to be solved, voices that deserve to be heard, and methods that deserve to be considered. And if you're interested in conceptualizing policy at that broader level, Paul Kearney is the author of that book. It's a beautiful book. There's 2 versions. And in the late 90s, we had a policy monopoly that included the medical profession, the FDA, other agencies, leadership of pharmacies and pharmaceutical organizations, medical educators, healthcare regulators, obviously marketers of drugs, which I should have there, who all kind of agreed that the problem is pain and the solution is going to be more prescription. And it was kind of a self-regenerating, incestuous circle of conversation. And typically, once that happens, the people who are now aligned ideologically and financially will work to counter opposing views. And that is the thing that you see in that show, Dope Sick, is Art Van Zee is saying, gosh, there's a problem here. It's not working out. People align and push back and say, well, we can't trust you. What do you know? So there was this push to address pain. My own employer is actually the agency that put pain as a 5th vital sign right on its teaching materials. There was weak regulation. Pills and prescribing were always more profitable and remain more profitable in many ways than other types of pain care, unless you are, able to do some of those highly compensated procedures. And the background for this crisis is crucial, and it's often not stated, that when we went through medical education, particularly those of us before 2001, there was really no training in pain, no training in addiction, no training in disability, and no training in rehabilitation. All of the key disciplines required to understand and interpret the claims that were made to us by the marketers. Imagine if somebody came to you and said, you know what, I want everybody with any kind of heart problem to get amiodarone right now. All of us who went through medical school would say, wait a second, I know amiodarone is a drug, and I know things about different kinds of heart problems. I'm not sure that claim is tenable because of what I learned. But in this case, the opioid promotion was in the context of medical schools and residency training programs that he'd elected never to provide the underlying training. And I must emphasize, as much as we could be angry at corporations, there is no corporation that forced our medical schools to not provide this training in the 1980s and the 1990s. They did not provide it of their own accord. Nevertheless, in that context, it was ripe for exploitation. And here's a picture, of course, of an OxyContin advertisement. I think the fact that these ads are illegal is a problematic thing, personal opinion. Pain is presented here as an orthopedic condition. If you take the pill, you can run upstairs, apparently. The 12-hour claim on the OxyContin pill was, of course, contradicted by data that Purdue had in its hands. And these pills were, prior to their reformulation, very easily broken to get an immediate and enormous dose, which could cause overdose right away. There were rivers of pills. This is a book where I've read parts of it in the review, Death in Mud Lake, which really is about distribution. And there was this kind of ecosystem of pill mills and Blythe pharmacies. I'm kind of giving a crib of Sally Sittel's review of that book, which in the Charleston Gazette Mail. And one of the questions that arises when you read these stories is, how do you reconcile the structural causes of addiction, like poverty and social malaise, with the fact the users and the sellers also were making choices? It wasn't that they were forced to make all the choices they made, as those distributors did what they did. And it's not always brought into the fore that these are choice-making people. But we're now in a new time. And so I want to introduce how policy shifted, because we've been reducing a lot. If you look at the new CDC guideline draft, it has the word individualized, I don't know, several dozen times. It has cautions against mechanically implementing some of its recommendations dozens and dozens of times, because we just went through something else, that massive reduction where we got back to 1993 levels in just 9 years from our peak. It took 20 years to get up to the level we were at in 2012, just 9 to reverse all the way back to 1993. So this is my model for why practice changed so much and so quickly. I put them in 4 boxes. There are governmental agencies like the Congress, which has, within the law passed in 2018, an actual requirement that there be dose limits in Medicaid programs. The Health and Human Services and the Food and Drug Administration have many agencies that influence prescribing, including CMS. The Department of Justice and the DEA both announce their prosecutions and send letters of warning to doctors based on prescriptions. If you're in Canada, Provincial Regulators Act, boards and colleges. We're all subject to guidances and metrics, CDC. If you work in the Department of Defense and VA, we have our own guideline. In Canada, they have theirs. National Committee for Quality Assurance has a quality metric that simply counts the number of patients at doses over 90 and counts that as bad care. In the lower right-hand corner, the payers have a lot of influence. I didn't put distributors, but they do too, but pharmacy chains and benefits managers, whoever you work for. And then finally, most of us doctors just do not have the time to read actual documents from all these agencies. So we're influenced by the voices, which are sometimes just what we hear on NPR or in a newspaper, what advocates say, and that influences our posture about these prescriptions. I have residents now who come up to me and say, look, I've made a decision. I'm just never going to prescribe opioids. It's simple enough, isn't it? Which we have to say, well, it's not that simple. So there was an alliance of scientific assessment, financial interests, and political pressure to reverse, which actually echoes the prior policy monopoly. One group missing from this discussion, however, I do want to note, where are the patients? Their lives are at stake, but they have not been prominently included by any of the parties listed on this graph, even though it is their care that's being changed. Just to give an example of the quality metric, this is from the National Committee for Quality Assurance. It's important to every health insurance program. They measure the use of opioids at high dosage. NCQA counts the number of patients over 90 as a percentage of plan members as bad. They have a denominator that excludes people in hospice care or with cancer, but it doesn't take into account if the patient had been on 120 for the last decade. The only way to optimize your metric is to either taper or stop the relationship with the patient. So this is a metric that incentivizes dose reduction across the board, similar to, say, if a medical board says, we will just investigate everybody who has patients at over 100 milligrams, the incentive then is to reduce them all in order to avoid professional liability and risk. So these are enforced and used by not just payment programs like the 5-star program from CMS, but it's built into the legal investigation thresholds, or at least it's hinted that it is, in documents I've seen both from Office of the Inspector General, from HHS, and the California Medical Board. So that's a pretty powerful way to change care. But there is one uniform agreement, even when any entity that would adopt that metric would all agree that there's one thing we should not do. Don't stop opioids rapidly. In fact, the FDA issued a warning in 2019. I actually played a role in getting data to them, and they issued a warning against sudden discontinuation. And yet the one thing everyone agrees we should not do, and this is crucial to understand, is the thing that happened. And this is not just a opinion statement. There are at least 3 large studies showing on a national basis that rapid stoppage became the norm. I'm showing a couple of them, but this is by Hanna and Naprash and published in 2021, looking at Medicare Part D. In relative terms, long-term opioid recipient discontinuation increased by 49% from 2012 to 2017. I think we can trust it increased further from 2017 to 2022. And the proportion of stoppages that was abrupt also rose during that time. Similarly, Brad Stein published a paper looking at 2017-18 at high dose patients. They had a different definition for rapid stoppage, but it was a credible one. Brad Stein is from Rand Corporation. They found 810,000 discontinuations, but 72% were rapid. So the one thing we all agreed would harm patients that should never be done, barring some extreme situations of criminal patients, that became the norm. So hopefully you're feeling a little uncomfortable as you listen to this and you say, wait a second. Are you saying, Dr. Kertesz, that we're stopping a problematic drug in the wrong way? Or are you beginning to say that opioids are helpful in ways that we're afraid to say aloud? And the answer is yes. I'm actually saying both. So we do need to detour very slightly. We need to talk about how bad or how good are opioids. This is a very short take on what could be a very long debate, but I want to respect the time. If we had some other treatments that routinely worked well for persons with severe long-term pain, I'm really not thinking about immediate postoperative care, but I am aware that there are probably experts in the audience who deal with short-term procedure care without opioids or with opioids. But the long-term pains, we wouldn't consider opioids because there's a lot of downsides. We don't have this other treatment that routinely works well. So we make ethical trade-offs. We say, gosh, let's talk to the patient. Let's talk about the risks. We might take the risk in some situations. I need to be very clear. Opioids evidence in cancer or sickle cell disease is not any stronger than it is in, say, ankylosing spondylitis or multiple sclerosis. But we have always granted an ethical leeway, basically because of a collective ethical choice that if it's sickle cell disease or cancer, that's okay, but that it's not okay in these other diseases. I'm going to talk about what we do know from randomized controlled trials in the next 2 slides. But I do have a warning about randomized controlled trials, which is that they are valid. They're valid by virtue of the randomization. But when you randomize a group of people, voluntary people, we don't really know the recovery context, the pain recovery context for each of those individuals. This is the same issue that arises in randomized controlled trials of addiction treatment. We don't know where they were in a process in relation to their community and their disease and their history. It's all hidden in order to get a valid comparison of 2 trial arms. But when we practice medicine, we actually do pay attention to those things. So sometimes the trials hide as much as they reveal. But that caveat stated, the Agency for Healthcare Research and Quality has a review of randomized controlled trials of different treatments, one for opioids, one for non-opioid pharmacologic solutions. And they updated it and they say for opioids, there's small benefits versus placebo for pain or function in trials of 1 to 6 months duration. They say that there's a lack of trials against placebo greater than 6 months. There is one trial that goes to 12 months. It's small. It's Volunteer Veterans by Aaron Krebs, my friend. And on average, opioids in that aggressive opioids did not outperform non-opioids in that one trial, although both arms improved. In German reviews used for the preparation of the European clinical practice recommendations, they don't call it a guideline, they argued that there was a lack of benefit versus placebo if the goal was relief greater than 50%, although in low back pain, they had a standard of 30% and they found a benefit versus placebo. I note some conflicts of interest for the AHRQ experts and for the German reviews. Outside of opioids, we'd love to find out that there's something way better. And unfortunately, that's not the case. Both with non-medication treatments, the effect sizes are all small, all the trials are short. what maybe one that's not. I think there's couple of behavioral trials that go longer. And for non-opioid medications, a lot of poor quality trials, a few good quality trials. Most are short. Most don't have long-term benefits. So we're kind of in a difficult choice space. And this is why I wind up proposing that we think about the patient with pain in a way that doesn't look like this diagram. So the temptation is to say patient with pain, arrow, prescription opioid. Most of us don't say that anymore, but it looked like we were being told that. And then, oh, prescription opioid causes overdose. I think of it this way. I have a patient with long-term pain, and I evaluate that patient in the context of biological and tissue injury, psychological history, social context, family, responsibility, disability. What are they able to do? What has the health system already done to this patient? That's a big story of the Lawrence suicide. There had been a lot of trauma from the health system. And what's their life context? And these are all things which we are not taught to think about in a systematic way, but you have to assess to come up with a good plan. So we should be taught them in a systematic way. And then I decide not whether to prescribe an opioid. I decide which of these things might be possible and then have a conversation about it with the patient. And that's a framework in which a lot of weak treatments are considered in a complex but appropriate scenario. So back to that reduction. Obviously, there's a lot of earnest debate about whether the reduction we achieved has yielded a benefit. We don't see it, but there are people who would argue that had we not reduced, those curves that are going up really fast would go up faster. And there are other people who argue that we sped up the acceleration of overdoses by reducing prescriptions. I don't think it's clear which one is the dominant argument, but we have not yet had the benefit we would have wished to see, that's for sure. There is one benefit I think we should acknowledge from the prescription reduction, which is that in federally collected, but properly collected anonymous survey data of high schoolers and also young adults afterwards, it's called the Monitoring the Future study. There are two stats collected on the use of opioid type pills. The Vicodin question only started in 2002. I think it's odd to have one drug like that named, but it went down from 2002 to 2020. The narcotics other than heroin question began in the 1980s, and past year use of that is at the lowest level on the record of the Monitoring the Future survey, which goes back to 1988. So if the goal was to reduce exposure in young adults, one could declare victory on that front now. So I'd like to turn at this point to the issue of the taper and stoppage in long-term recipients, given that I've already acknowledged that I would be one to sometimes start long-term opioids in patients with severe complex pain if the contextual issues and the other life issues led me to that decision in a consensual discussion with the patient. But if you're considering taper or stoppage, which is the thing we've incentivized, we need to talk about the evidence for it. I want to present an argument for stopping or tapering opioids first. There are clearly risks to prescribed opioids. Those risks in large retrospective studies, at least 3 that are commonly cited, do strongly correlate with the prescribed dose. The graph or the table on the right shows Veterans Affairs outcomes, admittedly from a while ago, 2004 to 2008, but this is probably the most commonly cited study in the CDC 2016 guideline and in all guidelines that have come since, which is by Amy Bonner. And I have taken the information for the chronic pain veterans out of that paper and recomputed how many overdose deaths would occur if you treat 1,000 veterans for a year in the years 2004 to 2008 at each dose. Now, her paper does not take into account whether they were co-prescribed benzodiazepines. It certainly is from a different era compared to how we operate in the VA today. But at over 100 morphine milligram equivalents, 14.9 would suffer an overdose death. At 50 to 100 milligrams, you treat 1,000, 8.0 would suffer an overdose death, and so forth. So there is a risk that may all be caused by the dose. We can debate that, and it correlates with dose. And I think the other thing that people who work with patients who have long-term pain and have had a volatile or difficult outcome from prescribed opioids, they will say there's a lot of volatility that can emerge in the pain experience itself and in the emotions that the person feels in the context of their dependence. And that may not be opioid use disorder diagnostically, but it may be. Another argument here for potentially stopping or tapering is a review from 2017 by Joe Frank, who is a friend and collaborator. They looked at 40 studies, including 5 randomized controlled trials with 261 patients. I just want to caution that's a very small number. These were short-term trials with patients who volunteered for stoppage, usually with multimodal high-touch service. So it's not typically what I see my primary care peers do. And they said there's very low quality evidence that opioid dose reduction may improve pain, function, and quality of life. And they cautioned they didn't have evidence at that time on potential adverse outcomes. But that review was updated, and it was updated by Mackey, another VA author, a rapid review with 19 more applicable to veterans. And they actually softened the conclusion and said the net balance of benefits and harms of long-term opioid therapy dose reduction were unclear, including unclear for harms from that reduction. Further data that could favor tapering is from the VA EPOC study. This is led by Dr. Erin Krebs. She's at University of Minnesota. They're looking at, it's an observational study where they collected surveys from 9,253 veterans who had been on long-term opioids from 2016 to 2017. And then they are doing a subset or getting resurveyed, and they're also looking at the medical records, which you can do easily in the VA. And at baseline, the first thing you can note is of these veterans on long-term opioids, over half rated their pain care as fair or poor. So it's not like they were saying this is wonderful. These are, the greatest thing in the world. And there is a very, very, very small paper from a subset published by Joe Frank again, saying that there was not a difference in the pain between the people whose doses were dropped involuntary versus voluntarily. I don't think Joe himself would advocate that you do involuntary dropping, but he wanted to publish that paper. There's also another paper out from the same group that found in the discontinuers, it appeared there was a decline in an adverse outcome. The adverse outcome was very complex, however, and it combined accidents and wounds and opioid and alcohol and non-opioid medication accidents, overdoses and injuries. And there's 2 spelling errors in that one line, but that was subject to sensitivity to what kind of statistical model they used. But this is as good as the evidence will get for tapering. So what might disfavor what we've been doing so much for the last 6 years, especially? Again, opioids are not ineffective for pain. That's where we're at. They're not ineffective. And normally with complex decisions, we try to individualize the decision to the patient in front of us and discuss the risks and seek informed consent for complex decisions. So what I want to show you is that the prescribed dose, although it's one risk factor for poisoning deaths, it's not the primary one. And unfortunately, reduction or stoppage appeared to be associated with risk. This is actually also by Amy Bonnert, whose paper I just quoted, but it's a detailed exploration of the relationship between dose and a drug poisoning death. And the red line, it's a case control. The red line is the cases. So the cases are veterans who in her original cohort died of overdose death. The red line and the gray line is controls who did not. The red line is displaced to the right from the gray line, which means that there is some tendency for higher dose to be received among the veterans who did die of overdose death. But if you look carefully at the red line, you'll suddenly notice that its peak is at under 50 milligrams per day. And suddenly you realize, oh, most people, and we've repeated this in BA data as part of my team, most people who die of an overdose death while receiving a prescribed opioid are on low dose opioids. That's because there's so many of them, but it also means that the way we're thinking about the problem is probably not correct. And if you're going to create dose thresholds as the basis for protecting a population, the one thing I can assure you is you will not protect almost all the people who will suffer the outcome, because you don't have a window into what's going on with those people, because the dose threshold is simply missing most of the people who are having the event of concern. So we're going to use VA data again here. This is a graph this is a table which I will walk you through, but it's again based on Veterans Administration modeling that is used today, every day now, to guide opioid risk mitigation in the Department of Veterans Affairs. And we have a large model that calculates the risk for an event, overdose event, or suicide event. They can be seeking care for those things or actually dying by those things. And I'm just going to walk you through the first patient. Patient 1 is on 20 milligrams a day, has a bipolar mental health diagnosis, has medical diagnoses, including cardiac arrhythmia, hypertension, cancer, and they're on tramadol. That's a lower dose drug, typically 2.3% risk in the year for overdose or suicide event. Patient 2, higher dose, 60 milligrams. They have in the record tobacco, cannabis use disorder, bipolar anxiety disorder, bunch of medical diagnoses, recent inpatient mental health stay. That's the yellow line. They're on extended relief morphine. You would think they'd be at higher risk, and they are, 11.8% risk. I'm not saying they'll die. This is for events. They can turn up in the ER saying they feel suicidal. Okay, patient 3 is at 90 milligrams. Alcohol use disorder, other substance use disorder, PTSD, all on the record. You'd be scared about this patient. Their medical diagnosis is chorea. They're on a fentanyl patch, diazepam, gabapentin, polypharmacy. You expect the risk to go higher, and it does, 38%. Patient 4, 240 milligrams. Now you're probably scared out of your mind if you're like me. Opioid use disorder, sedative use disorder, tobacco use disorder, mixed drug use disorder, all on the record. This is a hypothetical run through the model, but admittedly, we've encountered these patients. This is their risk calculated using the VA STORM model is 240, 58 milligrams. Finally, patient 5, 270 milligrams, highest dose ever in our examples. Tobacco use disorder, and they have a mental health diagnosis of fear of injury, COPD, ER visit for suicide. So there's actually one suicidal ideation. So one worrisome event. They're on extended relief morphine, but their risk is 4%. A veteran on 120 morphine milligram equivalents with no other psychiatric diagnoses is at the same risk as a veteran on 20 milligrams who has post-traumatic stress disorder in VA data. Most of our risk mitigation today in the VA is on low dose patients who have psychiatric diagnoses. So you can't taper your way out of that because the problem is not that. Taper papers are, I hate the rhyme right now, but there are a lot of papers now that raise the concern. Stoppage in veterans is often followed by suicidal ideation and action, but this is a small retrospective study with no comparator. Dose variations, either upward or downward, were associated with increased overdose risk in the Kaiser, Colorado data, suggesting that stability is to be desired, not instability. Cessation of opioids from high dose in Vermont was almost always done in one day, with emergency care often needed. This is not a comparative study. In a small study from Seattle, from a clinic, a safety net clinic, cessation was associated with a 3 times increased risk of overdose death versus non-cessation. I think if you think about a small clinic where they might do this stoppage, you'll know that if they look in the record, they find that we're stopping in response to concerning behaviors in the patients. Indeed, that is what happened. They read their own records to check why they stopped, and they changed their clinic policy after looking at that data to have a better safety response. It was 572 patients. 3 more papers here, cessation in Oregon Medicaid. This is now a large study published. Actually, it says 2021, but the final version came out in January of this year, was associated with a tripling of the risk of a suicide event, some of which were lethal. And it didn't require just cessation. There was also people who had a dose reduction first and then a cessation. They also had that increase in risk. In Veterans Affairs data, which I was co-author to and which we shared with FDA, stoppage was associated with increased overdose and with suicide deaths. And that was published in BMJ. And then in US national data published last year in JAMA, taper was associated with an increased frequency of mental health crisis and overdose events. The graph on the right tries to show you the frequency of such events for the tapered patients, which is the blue bars, versus the non-tapered patients, which is the orange bars. Each of these papers has a challenge, of course, which is that it's retrospective comparative data. I'll come back. And just remember, retrospective comparative data can't see all the things that the doctors were seeing at the time that they were making the change in care, and that applies to all these papers of concern. But it also applied to Amy Bonnard's paper on dose and overdose, the same things that are leading us to make dose so central. Though those papers had the same limitations, and yet we allowed them to become thresholds in law to govern our care. At this time, we're beginning a qualitative study to look at a small number of suicides that happened after dose reduction, because we think that when a plane crashes, you should study it in depth, not just with statistics. And we're recruiting. The Veterans Administration recently indicated that they will award us $1 million to carry out this work. We're going through the IRB now to expand the study. As I mentioned, with retrospective comparisons, aspects of the clinical story are outside of the database, so be cautious. But it's regrettable, this caution was just not present when policies to incentivize dose reductions or to investigate people at doses over 90 or 100, when those were put in place, that caution about retrospective analysis was not present. So I'm going to conclude by offering my view of good care. This is not about how to prescribe. I'm trusting that you're getting guidance of, go slow, start low, that kind of thing elsewhere. But let me state my caveat. All discussions of pain care with opioids tend to become a referendum on the pills. And the reasons for that focus on the pills really, again, reflect that underlying lousy training that many of us have on pain and on disability. I mean, and can you imagine, for example, scalpels, are you for them or against them? The average person who's had a surgical rotation in medical school would say that is a little too simplified. Or antiarrhythmics, they cause arrhythmias, they don't prevent them. Again, we all know about the CAST study, the asystole outcome of giving lidocaine to every MI patient who has some PVCs, but that doesn't end the discussion of antiarrhythmics. You would think that in those situations, there's more going on here than is being discussed. So my suggestion is to recognize that's also the case with pain, and we need to engage in some honest discomfort with gray decisions. Of course, our lack of discomfort, our personal discomfort, and our desire not to be in gray decision mode is what allowed us to be exploited by pharma. Our reckoning with the failings of 1, 2, and 3, of course, has led to our collective reductions. We should use guideline safety tips and evidence, including the CDC's guideline, but pain care is not poison control. And unfortunately, I will say, the CDC has housed its guideline in its poison control division, which is a setup for not necessarily conceptualizing the problem the way we as clinicians need to, which refers back to this graph I presented earlier. Okay, if the framework for thinking about your patients is a good one, then most of the tips from the 2016 guideline are still good. The prescription dose risk idea is still reasonable when assessing whether to escalate doses. You need to have a very careful conversation about it. There are obvious strengths to that viewpoint. Opioids are not first line. It should be very uncommon and very justified if you are going to combine with a benzodiazepine, although it is not always prohibited. You have to carefully learn and then discuss with your patient, and I hope you do, but I would encourage open, careful, respectful discussion of risks and benefits. I do favor liberal naloxone co-prescription in my system. I just get pinged to do it. The patients are kind of used to it. They don't feel stigmatized at this point. They just know that the VA is sending naloxone out. And when they ask me, I'm like, I'm asked, this could help you, but you know what? You might see someone down and save their life with this naloxone. Be thoughtful about urine tests and PDMPs. Most medical boards expect to see them. Just realize that interpreting the results requires some time. Here's a case. There's not going to be a single right answer, but I want you to realize what it means to think about a case with respect for all the dimensions. Mr. Jones is a 56-year-old man with osteoarthritis and multiple joints and pain severity of 7 to 10 out of most of the time, 9 out of 10 at extremes. He had 2 surgeries that failed, knee and shoulder, in the past. His substance use issues are that he had heavy drinking prior to age 35 or so, and he has a 5-drink binge about once a month, he says, during SEC football, but sometimes NFL as well. Prior medications for the pain have failed. There's currently some anger in the family, some recriminations amongst family members, and it does seem to be happening at the same time that he tells you his pain is worse. He does seem to be someone who's trying to uphold work and church responsibilities. He did physical therapy a couple of years ago for 12 weeks. It helped a bit. That wore off. He tells you it's really far from where I work. It wasn't that useful anyway. So I wanted just to highlight a case that sounds real to me, kind of patient I see in my VA clinic. And if you think about this case, every dimension, I'm not going to go through all of them. Some of the ways to think about it are obvious in the case. He's osteoarthritis in multiple joints and pain severity. So there's some clinical science we could bring to bear here. We could say the SPACE trial by Dr. Krebs, published in 2018, there were two arms in that trial. One was aggressive opioid initiation and dose escalation versus using non-opioid therapies with reservation of opioids, which were in the non-opioid arm actually, but reservation of low-dose opioids at the end of a sequence, which hasn't worked. And in this case, Mr. Jones's story actually is like the non-opioid arm of the SPACE trial. He's kind of been trying all this other stuff, it doesn't work. So maybe he would be the person where even in the non-opioid arm of that trial, he would have gotten tramadol, which was in the non-opioid arm. But you wouldn't say it's going to be necessarily superior. In fact, you wouldn't have reason to think so. Maybe there's some pain science here that we can bring to bear on the fact that there's family anger that is occurring at the same time as his feeling that his pain is worse. You kind of have a hint there that his affect and his social support, maybe even some isolation, are making the pain worse. So you've got to converse about it. You got to say, I noticed you said that you've been in a lot of conflict. How's that relating to your pain experience right now? And what's going on? And is that, I've noticed that some patients really do have worse pain when they're in conflict with others. Do you have ideas about how we can approach that problem? You do want to deal with that. You don't want to set that aside. And then finally, there's a context issue with one of the treatments, which is we would often push for PT, but it's not really very available to him if he also wants to hold down a job, and it wasn't that good. So that's a context aspect that might influence the choice. So in that conversation, I'm not saying by all means prescribe opioids. I'm not saying by all means don't prescribe opioids. I'm saying the conversation with Mr. Jones can take into account science and context, and one could defend that decision of cautiously starting them if one wanted to. I've used this word context like 50 times in this talk. I collaborate with a long-term friend of mine, Dr. Saul Weiner from University of Illinois at Chicago and the Jesse Brown VA. And they have put context of care, they've tested it. They've shown that doctors often don't inquire about it. They've shown that when you do inquire about it, medical outcomes are better for disease-specific outcomes. Here's a video series which explains that concept, and you can check it up on YouTube. Just search Contextualizing Care. I'm here at a scientific meeting in Orlando. He's going to be presenting a randomized trial where they actually put contextual programming into both EPIC and Cerner and found that it improved outcomes for patients in the two hospital centers which they tried it out in. In thinking about the relationship with the patient, I admit this is a little bit of a shameless plug, but this relationship and how we converse and how we often fail to assess what's going on with patients is the topic of the latest episode of my podcast with Dr. Saul Weiner. I present a case of a very inappropriate dose escalation and a case of a very problematic dose reduction. In both cases, not in terms of policy, not in terms of clinical science, but in terms of what was going on in the relationship that these things happened, and why can't we remember how to communicate with patients in such a way that we learn what's going on. Okay, conclusions, and then I'm going to look at the questions I saw flash by in the chat. Our US opioid history reflects not just commercial forces, but underlying deficits in our training. Prescribing fell rapidly in ways that reflect multiple influences at once, superimposed on a lack of training. A lot of the reduction, we all agree, was not careful. Evidence that tapering a long-term recipient against their will makes them safer is at its very best unclear. Probably it makes them less safe, but at its very best, you can argue the evidence is unclear. I think our care decisions with these medications, but like all healthcare, should consider the clinical history and the patient context, and they should be based on a careful and respectful relationship to the patient as an equal. We're going to have a discussion in a moment, but I did see something in the chat, so I'll just briefly comment on it. It was, can we address the fact getting the genie back in the bottle as fast as we can approach is now being recommended for gabapentin. Right, I think the two things that happen in the middle of a rapid change where one drug has come to be seen as very bad is then for a while, everyone's reaching for, well, what's the next drug? I even started seeing patients in my own hospital who are now on lower dose opioids, but 2 other sedating drugs at the same time. So rather than just high dose opioids, which they were tolerant to, my colleagues were putting them on low dose opioids plus gabapentin plus carisoprodol, and the patients were falling asleep in the office. And then they would note patient sleepy today in the chart. So all of this, I think, is best addressed as there are some indications for gabapentin may be helpful. If your reason for giving gabapentin is to make a dose number go below 90 because you're being incentivized to do that, that would not be a strong reason to do that. And in the obviously gabapentin's evidence base is strongest with neuropathy. So I would be careful with starting it, but getting every single person off of something, we just don't have evidence that all these stoppages are creating safety. We have no such evidence. And we normally talk about uncertain situations carefully with patients.
Dr. Kertesz's presentation slides can be found at addiction-medicine.org, along with information on both our Spring Addiction Medicine Conference and our Fall Addiction Medicine Essentials Conference. Both events are put on through partnerships with the North Carolina Society of Addiction Medicine, with funding from the North Carolina Division of Mental Health, Developmental Disabilities, and Substance Abuse Services, the North Carolina Division of Public Health, and the Substance Abuse Mental Health Services Administration.